Good afternoon, folks, and thank you for joining us at the, crazily enough, January 2023 Da Vinci Community Roundtable. And we've got a full agenda for you today. We'll get started momentarily, but first I'm going to do a little bit of housekeeping. So first, I just want to remind folks that Da Vinci lives under HL7's antitrust policy, and so everything that we do around Da Vinci is mindful of anything that could be construed as antitrust and moving the industry forward, sharing standards. First, I'd like to just do a welcome and some housekeeping for everyone. So I'm really excited about today's agenda. For folks that don't know me, I'm Jocelyn Keegan. I'm the Da Vinci Program Manager and the Payer Practice Lead at Pointing Care Partners. We have a wealth of experience and knowledge around the space on the existing federal rules that we're going to review today, and then the Da Vinci assets that support them. I'm excited to have Bob Dieterle, who is one of our original founding members of the PMO and one of our senior advisors, also our lead for burden reduction. Mary Green from the Office of Burden Reduction is joining us, and Dan Kalwa, who's Acting National Standards Group Director, and on the for the Office of Burden Reduction and Health Informatics as well. I'll be facilitating today's conversation, and we're also joined by Alex Muggy, who's the Director and Chief Health Informatics Officer at CMS, and lastly, Viet Nguyen, who's my counterpart on Da Vinci as the Technical Director, but also the Chief Standards Implementation Officer, new division of HL7. So for today's conversation,
we'd love it if you could advance the slides. They're not advancing for us.
Oh, they're not.
No.
So bizarre. Apologies. Okay, can you see them now? I think I had accidentally paused myself.
Yes.
Okay.
You're on housekeeping.
And for folks that take screenshots, I'm going to stop for a second and go back to who's speaking today, so you can do your LinkedIn Googling in the background while we're presenting. And then just for housekeeping, we've been doing these meetings for a couple of years now, but just to remind folks to keep your lines muted to aid in the quality of the recording. You have the ability to ask questions. We will handle Q&A in line of commentary if possible, but we are working to preserve some time at the end of today's discussion for Q&A at the end of the presentation. If you're having any issues with your audio, we have found time and time again that just dropping and dialing back in or dialing in by your phone number that's available to you is the best way to be able to resolve issues. And we really appreciate folks answering the survey questions at the end of the webinar. So if you can just hang out for a minute as you're leaving and give us some feedback, that would be fantastic. As you know, we do these community roundtables once a month. We're slated to have the next session for February 22nd. We were just talking this morning actually about hopefully sharing some of the early recommendations and commentary coming from Da Vinci on these two MPRMs as part of our February lineup. But if you're not on Da Vinci's listserv, that's how you'll be notified of the full agenda and the timing and the sign up for that. And if you have not been familiar with it, Da Vinci keeps an active calendar with both the recordings of sessions like today and the slides, but also you can follow that page to also, when we make updates and additions to it, so you can become aware of when additional sessions information has been posted. Just a little bit of housekeeping on what's happening from a Da Vinci perspective. So we're planning to support updates around Da Vinci at the State HIT Connect in Baltimore coming in March. We are working with HL7 and the folks from Vive to understand where and how Da Vinci members will be participating and demonstrating at Vive this year, and we'll also are still in finalizing plans for Da Vinci at HIMSS 2023. And then lastly, for folks that joined Connectathon just last week in Nevada, we're actually already organizing and getting prepped for the May Connectathon at HL7 in New Orleans. And alongside the Connectathon, there'll also be the working group, and HL7 is in the works, and you'll see more news about it shortly, about making it a working group plus really with adding some additional content on the accelerators and work products coming out of accelerators for implementers specifically. So if you're not following the HL7 listservs, I would recommend you do that. And a reminder that we're actually going international for Dev Days in the HL7 world this year. So Dev Days will be in Amsterdam in June. So for today's update, we're really diving into two specific topics, the two proposed rules that dropped back in December. We've been, I would say, sort of colloquially referring to CMS 0057 proposed rule as Interop 3 will be the language that we're using today. And just for folks that haven't been following along from home very closely, this is really a long expected publish of a rule focused on bringing much of the work that we've been doing within Da Vinci with payer to provider collaboration in and alongside in coordination with the work to reduce burden for payers and providers from a workflow perspective, and then a long-awaited rule on attachments, CMS 0053 proposed. And so Dan's going to give us an overview about really, what is the update around where we're headed with HIPAA and administrative simplification, and the details here if you haven't seen the full rule to be able to get to them. I'd also like to do a broader reminder to folks that we actively renew membership and add new members for Da Vinci in the beginning of each fiscal year. So if you haven't gotten more closely involved in the project, we'd love to have you get more involved. And here's some basic information, just the highlights for today for this audience, I would say is, there's really an ability for people to participate at every level in the project. This is a party of the willing, I would say it's a human-powered project, and the funding allows us to develop these standard implementation guides, I think at a pace that has really been remarkable over the last 5 years. And the project itself is based on HL7's process and really making sure that we're being fully open and getting community feedback on the guides as they develop. So with that, I'm going to actually move us to the body of today's conversation. And so we're going to do a deep dive into both proposed rules. I'm so thankful. I would say, I think if you had asked me 5 years ago when we started the project, with interest and support from payers, providers, and vendors, and our colleagues at CMS, that this is where we would be today. It's really striking to look at sort of the body of work. And I'd personally like to thank both Dr. Green and Alex for their support, not just from the program perspective, but really the day-to-day work they've been involved in from a governance perspective with the project, and the in-kind resources from CMS through MITRE and Lantana to provide the fuel in the body. We're at a point in time where industry is really driving where regulation is happening, and where standards are going, and the alignment that we're getting from a regulatory support perspective from our colleagues is remarkable. As I mentioned before, Bob and we'll be doing a deep dive into sort of the Da Vinci guides that support the Interop 3 rule, and then Dan will be doing a deeper dive into what exactly is in the attachments rule, and Viet's going to take some time to talk about the capabilities that are coming available with our clinical data exchange guide, CDEX, in support of the ability to move supplemental data around in the industry. And with that, I'm going to hand it off to Mary.
Great, thanks a lot, Jocelyn. Hello, everyone. Thank you for joining the call. I'm happy to start us off here. I'm going to talk about 3 things. One is why prior authorization is important. The second is why the process needs to be better. And the third is how our proposed rules are helping the cause. So you've probably heard me talk about this before, but prior authorization is a utilization management tool, and it's an important one. It helps control costs and ensure claims are paid accurately. Through the prior authorization process, plans verify ahead of time that an item or service is actually medically necessary and it meets coverage criteria. They also determine whether the item and service is consistent with the standards of providing medical care. But when it's tough to get through the process, or burdensome, or onerous, whichever word you want to use, that's a problem for everyone involved. And it's not just a problem of inconvenience. Prior authorization is a leading cause of burnout among clinicians. Providers spend staff resources to figure out what the prior authorization requirements are, to navigate the data submission and approval processes, to deal with denials and appeals. And these are resources that would be better spent actually providing patient care. And as you all well know, phone calls and fax machines are still a necessary part of getting through the process. And to add to that complexity, prior authorization requirements and processes aren't the same across payers. So if you're in a practice that deals with, say, 10 or 12 plans, you have to navigate 10 or 12 different sets of requirements and processes. That's a lot of time for providers and certainly for providers' staff. Payers are impacted too. Payers experience having to redo work when they don't receive upfront all the information they need from providers to decide whether to approve or deny the request. And the impact on patients is particularly concerning. Patients pay out of pocket unnecessarily or abandon treatment altogether when prior authorization is delayed. Some worry that they'll get sicker or even die while awaiting their prior authorization decision. So that's why it's critical to ensure the prior authorization process is efficient, transparent, and standardized. And that is exactly what the goal of our two rules are, to make prior authorization processes more efficient, transparent, and standardized. So the interoperability and improving prior authorization proposed rule, which Alex is going to be talking about, it's intended to enhance patient and provider access to health information and to streamline prior authorization processes across different sources of health coverage. It proposes new requirements on payers to improve the electronic exchange of health data and to support electronic prior authorization. It also proposes timeframes around how quickly some payers would need to respond to prior authorization requests and require payers to publish certain metrics around rates of approval and rates of appeals. Sometimes in the prior authorization process, providers need to send more complete clinical information to payers. Sometimes it's medical charts or X-rays, documentation of referrals. That's where the attachment proposed rule comes in that Dan's going to talk about. The attachment proposed rule includes proposals that would adopt standards for healthcare attachments transactions, and that would support both healthcare claims transactions and prior authorization transactions. So together, these two rules ensure patients, providers, and payers have the information they need to get through the prior authorization process and get to a decision faster. And patients may be able to get the care they need more quickly. It gives patients more visibility into how plans handle prior authorizations, and that information might be particularly helpful to them when they're selecting health plans that they want to join. Finally, the rules help make the technical approach more standardized across Medicare, Medicaid, and marketplace programs, which will make it easier for providers to navigate the prior authorization process. This work was informed by numerous listening sessions and interviews from providers, plans, patients, professional associations, health standards development organizations, and technology companies, and actually other kinds of stakeholders as well. It's also informed by comments from previous rules and input that you all have provided as well. The comment period for the rules close in March, so please consider submitting comments. I do want to mention one more rule just for your awareness. The panel won't be talking about that rule today. CMS released another rule in December 2022 that also has proposed prior authorization provisions in it. And this rule was released by the Center for Medicare in the 2024 Medicare Part C and D proposed rule. Those proposals are specific to Medicare Advantage and relate to clinical coverage criteria and streamlining prior authorization processes. They are not technology or standards proposals, but it's important for your organizations to be aware of them, and at the very least to have a broader mental model of burdens related to prior authorization, burdens that go beyond a technology or standard solution. So here's one example. The rule includes a proposal to require MA plans to have a utilization management committee led by the MA plan's medical director that annually reviews all utilization management policies and procedures, including prior auth. Here's one more example. The rule includes a proposal to require MA plans to have sorry, I was just going to repeat the same thing. A proposal to require a physician or other appropriate healthcare professional with expertise in the field at issue. So, for example, if the prior authorization issue is a heart issue, a cardiologist would be expected to review. That appropriate clinician should review the prior authorization decision or to deny coverage before the denial actually happens. So they just want to make sure that the right clinical background, a person with the right clinical background, is actually reviewing the prior authorization if it's going to be denied. So these proposals address pain points in the prior authorization process that create burden, and again, like I said, are primarily have non-technical solutions. So I'm going to stop there. I want to thank all of you for your work, the work that you're doing to make prior authorizations more efficient, transparent, and standardized. I want to echo what Jocelyn was saying. The work that you've been doing has been fantastic and enormously helpful, and your input to us has been enormously helpful. So let me turn it over to Alex Muggy.
Thanks, Mary. Thanks to everybody for having us here today. We have sort of a lot to cover with you, so I'll probably run through this a little bit quickly. But of course, my name is Alex Muggy. I'm the Director and Chief Health Informatics Officer at CMS, and my team is, as part of Mary's team, is responsible for the interoperability rule that you're going to hear about today. So like I said, we're going to be, we have a lot to cover today and a pretty short amount of time, so I'm going to jump into it, but I do also want to give a little bit of context up front. So if we could stay on this slide for just a second, I promise I'm not forgetting to advance them, but I'm going to stay here for just a minute. Because we at CMS, we like to talk about this journey to interoperability, and it's a journey that we're all on together with the foundation of privacy and security, and to ensure that patients and their care teams get access to the data that they need. We've done a lot of work on interoperability and standards recently, and you're going to hear more about that today. And of course, I know all of you are very familiar with that, but we'll share some more information here on that today. And it's a lot that's happening and changing in the standard space. And I think that it's a really important point that we're at in this evolution and journey to interoperability, where we have a lot more standards and technology available to us to make this future of interoperability a reality. So with that, let me give a little bit of the background context that led us to where we are. You all may be familiar with two of our previous rules. I'm going to talk about this like a trilogy, and I think that Jocelyn and Mary already teed that up a bit when they talked about Rule 3. So the first interoperability rule, or what we refer to as Rule 1, was the Interoperability and Patient Access Final Rule, and that was published in May of 2020. A lot of those policies, or all of those policies, actually, I should be very clear, all of those policies are in place today, so they've already been implemented. But that was a significant rule because it was the first time that we really engaged payers in the interoperability space, the first time we introduced requirements on standardized APIs for payers. So again, we'll refer to that as Rule 1. And then in December of 2020, some of you may remember that we published another proposed rule that we called the Interoperability and Prior Authorization Rule. That rule was never finalized. So it remained a proposed rule, but with this new rule, Rule 3, we are withdrawing that rule, which was Rule 2, and we are replacing those policies with some better informed policies that have a little bit more feedback that we've gained from the comments that we received on that second interoperability rule. So we've taken Rule 2, the feedback we received, the advances in technology that have happened since that date, and we've introduced interoperability Rule 3, which is what I'm going to cover today. So perhaps we can skip to the next slide now, which is just going to be a quick overview of this next, there we go, thank you, of this rule that I'm going to be covering today. So on December 6th, we released this proposed rule with the short title, Advancing Interoperability and Improving Prior Authorization Processes. The comment period for the rule is open and will remain open until March 13th. So make sure that you're getting your comment letters ready. This rule, of course, demonstrates our continued commitment to interoperability and to reducing burden in healthcare. As Mary referred to, or gave a good overview of, prior authorization, while a necessary process, has also historically been a significant source of burden. And with this rule, CMS is attempting to streamline this burdensome process and save time for clinicians so that they can put that time back into taking care of their patients. A couple of rules up front, or disclaimers up front about the rule. While we talk about prior authorizations throughout this presentation and throughout the proposed rule, we want to be very clear that we're talking about prior authorization for medical items and services only. There is nothing in here about drug prior authorizations. So just to be clear, drug prior authorizations have their own standards and their own rules. In this rule, we're only talking about medical items and services. The second thing I want to point out about each of the provisions in this rule is that they all have an implementation date of January 1, 2026. So I won't repeat that for each of the APIs and policies that I'm going to cover, but just know that for each of them, the implementation date would be January 1, 2026, if finalized as proposed. Next, another quick little fun fact that I like to share. We know that there would be some upfront costs associated with this rule, as there is with any new implementation, but it's important to note through our cost estimates that we anticipate this proposed rule could save the healthcare industry $15 billion over a 10-year period based on the reduction of time spent on prior authorization alone. So that is significant. Those savings do outweigh the cost of the proposed rule. So just something that I'd like to note and make sure that others are aware of. So this proposed rule does include proposals for both payers and providers. When we talk about impacted payers, we are talking about the Medicare Advantage organizations as part of the Medicare Advantage program. We're talking about Medicaid and CHIP fee-for-service agencies, so state agencies, as well as Medicare and CHIP managed care organizations. And finally, the qualified health plans in the federally facilitated exchanges. So almost every payer that CMS regulates would count as an impacted payer as part of this proposed rule. When we talk about the impacted providers, we are talking about eligible clinicians, eligible hospitals, and critical access hospitals that participate in the promoting interoperability programs, or what was the meaningful use program. And then finally, there are 5 RFIs in this rule that are also available for comment, and we'll go over those really super briefly in just a moment. But if we can go to the next slide, we can dive into an overview of the actual provisions of this proposed rule. So I'm going to start by just covering the proposals for payers, and there at the top of the slide, you have the list of the impacted payers once again, just for reference. But jumping into the provisions here, so the first is that we are, well, as part of Rule 1, or the Interoperability of Patient Access Final Rule, we finalized a patient access API that would allow, that required payers to make data available through a standardized or FHIR-based API, so that patients could access their data directly on their smartphone or application of their choosing. That policy has already been implemented and is in place today. But in this proposed rule, we're proposing to expand on that existing API and also require payers to include information about prior authorization requests and decisions. So that would allow patients even more access to their own data. So taken together, the patient access API would now include claims and encounter data, which includes provider remittances and enrollee cost sharing data, as well as all data classes and data elements in the US CDI, which is a content standard that ONC has previously adopted and we are now pointing to with our patient access API, as well as data about the patient's prior authorization requests and decisions. All of that data in one place for patients to access. And then just a quick note, in the proposed rule also includes a proposal for payers to report metrics, usage metrics about the patient use of the API to CMS on an annual basis, so to give us a better sense of how much these APIs are being used. The second API we're proposing for impacted payers is the provider access API. We are proposing to require, once again, that this be a FHIR-based API, and that payers make this API available so that providers can have direct access to really the same data that patients are looking at in the patient access API. So that would include all data classes and data elements in the US CDI, claims and encounter data, which For providers, this would actually exclude the provider remittances and enrollee cost sharing information that was only available to patients, but it would still include the claims and encounter data, just not the dollars. And then it would also include that information about prior authorization. So again, providers having the same access to the same data that their patients have access to. Then the third API that we are proposing is actually replaces a previous payer-to-payer data exchange policy that CMS had previously finalized. We are replacing that with the payer-to-payer API, which is, once again, a FHIR-based API that would require payers to exchange data with other payers as a patient moves from one payer to the next. And that API would, again, include all data classes and data elements in the US CDI, claims and encounter data, excluding provider remittances and enrollee cost sharing data, and would include the prior authorization data. So in this way, we've got patients, providers, payers, all having access to the same information about the patient and being able to use that information to make the best possible care decisions on behalf of the patient. And even given that payers have access to it, potentially make coverage decisions as well in terms of whether or not to extend a prior authorization or next steps in providing the best possible patient care. The next set of proposals really gets to the nitty-gritty of the prior authorization process. So far I've talked about the concept of data sharing and transparency, but that's been a one-way data exchange with payers sending data to patients, providers, or other payers. This next API uses more of a bi-directional data exchange approach to help facilitate the prior authorization process. So we are proposing to require that impacted payers would build a prior authorization API that would allow clinicians through their own EHRs or practice management systems to, one, query whether a prior authorization is even required for a particular item or service. Two, if it is required, determine what data and documentation are needed to submit the prior authorization. And three, would actually help to facilitate the process of submitting the prior authorization request. And I say it that way, that it would help to facilitate that process, because while this is another FHIR-based API, in order to be HIPAA compliant, it would have to work with the HIPAA administrative transaction standards for prior authorization, which is the X12278. So these standards, in this way, coming together in a hybrid approach to make this the best possible user experience and encourage electronic prior authorization in a HIPAA compliant fashion. So we're hoping that in this way, this API will help to streamline several of the challenges of prior authorization by standardizing and automating certain of the pieces of the process of prior authorization. We're hoping that this will reduce some of that historically time-consuming and burdensome effort that providers and office staff experience today. But we all know that prior authorization is a complex process, and it can't just be addressed by simply adding this technology layer. So we're not fooling ourselves that adding an API is going to solve all of the problems of prior authorization. As Mary mentioned, there is a separate prior authorization rule that was released about the same time as this rule that does include some proposed requirements for prior authorization. And our rule also includes some non-technical proposals related to prior authorization, which I'll cover really quickly here. I know I'm running out of time, but the first non-technical proposal is that we're proposing payers must include a reason for for denying a prior authorization. This is regardless of how the prior authorization is submitted. If it comes through the API, through a heaven forbid fax, portal, whatever the case may be. However the prior authorization happens, there must be a reason included if the payer is going to deny that prior authorization. This is for the benefit of the patient and for the provider to help them to determine either a different course of treatment or to resubmit that prior authorization with more success. The second non-technical proposal is that we are proposing to standardize prior authorization decision timeframes, and that would be for expedited requests 72 hours. For urgent or expedited requests would be 72 hours, and for non-urgent requests, for standard requests, it would be 7 days. So again, standardizing that across the programs there. And then finally, in an additional effort to bring even more transparency to the prior authorization process, we're proposing to require that payers would make certain metrics about their prior authorization performance publicly available on their own websites. Not sending it to CMS, but making it publicly available on their own website. So that would be metrics like how many prior authorizations are approved on appeal when they were previously denied, things of that nature, so folks can really understand the payer's performance in the prior authorization phase. If you could go to the next slide, I'm going to switch gears here. So everything that I've talked about up till now was a proposed requirement on the impacted payers for this rule. Now we're going to talk quickly about the requirements for the providers. So again, this includes eligible clinicians, hospitals, and critical access hospitals in the promoting interoperability programs. So to help ensure that we have uptake and adoption of this critically important prior authorization API, payers are going to build it. We want to ensure that providers are also going to use it. We are proposing to require a new measure under the promoting interoperability programs that would require these providers to report on the unique number of prior authorizations that are requested from the prior authorization API using data from their own certified EHR technology. So again, in this way, we're bringing in the providers, we're bringing in their technology and health IT developers, and we're getting everyone to meet in the middle here by establishing this API that helps to facilitate electronic prior authorization. Next slide, please. So on this slide, this is an overview of the required or proposed required standards for implementation of each of the APIs. These are standards that are already adopted by our partners at ONC and that we point to in our rule to say these are the required standards that should be in place for each of the APIs that I've discussed so far, plus the provider directory API, which was actually from Rule 1. So these would be required for the APIs as indicated on the table here. We're also proposing a process by which developers would have the flexibility to use updated versions of these standards without us having to do future rulemaking. We don't want to stifle innovation. We want to make sure that we keep innovating on these standards. So we're proposing a process, or I guess extending a process that we proposed in Rule 1 to this new APIs that would allow developers the flexibility, again, to use more updated versions of these standards that are required. On the next slide, we have a list of recommended standards. So these are standards, or these are implementation guides that we are strongly recommending, but we are not proposing to require in this rule. We do note that we may propose to require these in future rulemaking, and we really strongly hope that folks follow our recommendation. But at the time, these implementation guides are only recommended, but again, we hope that everyone will follow that. These implementation guides are what's going to get us to interoperability. It's one thing to use the same standard. It's another thing to implement that standard consistently across implementations. And these guides are what's going to get us there today. And as you can see, Da Vinci is very highly represented among the IGs that were selected for this because they, of course, support a lot of the payer use cases that I discussed as part of the APIs. So if we could go to the next slide. I believe this is a quick list of the RFIs. I'm not going to go through these because we're running short on time, but I do want to mention that while these RFIs cover a wealth of different topics out there in the healthcare space, they all link back to the use of technology and standards in healthcare to promote a better healthcare future. So everything from social risk factor data, maternal health, behavioral health, there's a little bit of something in here for everything. I must mention the TEFCA as well for my friends at ONC. So just take a look at these and please, if you have time to comment on these as well, really critical for the future of healthcare and the future of policy making and development that we do at CMS and you all do out in industry. Next slide, please. So as I've gone through this, I talked about how we talk about our rules a little bit like a trilogy. There was Rule 1, Rule 2, which has now been withdrawn, and Rule 3. But what I can tell you as well is that we're not at the end of this journey. We will continue developing regulations to support advancements in data access. We will also continue to directly support industry and innovation by providing in-kind support to organizations like Da Vinci to ensure that you all have the resources needed to drive a better healthcare future through industry engagement and the consensus process. These are critical for getting that implementation piece and getting us to that interoperability. Again, it's one thing to say use a standard, it's another thing to have consistent implementation, and that's what organizations like yourselves are working on when you're developing these implementation guides and working across industry to get that consensus process. And we support that and want to continue to support that. And finally, we are leading by example. Here at CMS, we are a payer after all. Sometimes it's easy to forget that we've got the regulation side and we've got the actual Medicare fee-for-service of our business, but we are a payer and we strive to ensure that we're advancing our own operations and our own customer service and benefit to our enrollees through the implementation of these APIs and policies in our own work. So I look forward to working with all of you as we move forward with, of course, the policy making and hopefully implementation at a later date. And again, we will be doing that in our own work as well. The next slide is a list of, you already got it. This slide is the list of helpful resources. I know I went through everything very quickly today. So for some of you where this is a little bit newer, I strongly recommend taking a look at these resources, and you can always reach out to that email address at the bottom if you have additional questions. And with that, I'm going to wrap it up and hand it over to Bob Dieterle, who's going to talk in even more depth about the implementation guides and the important work that's going on. So thank you all, and take it away, Bob.
Okay, I want to thank Jocelyn, Mary, and Alex for coordinating this really important community roundtable and providing insight into the proposed CMS interoperability and prior authorization rule that will have significant impact on the industry, in part by requiring HL7 fire standards and recommending the use of Da Vinci fire implementation guides that standardize the exchange of information between providers, payers, and new patients. Next slide, please. This is a summary slide that we use to introduce the scope of the Advancing Interoperability and Improving Prior Authorization Process Notice of Proposed Rulemaking for our conversations with Da Vinci members and community stakeholders as we work to assemble a response to the NPRM. It provides in one slide an overview of the material that Alex just reviewed, including covered plans, provider programs, effective dates, and scope of APIs. We'll refer to this NPRM for the balance of the presentation as Interop 3 NPRM. Next slide, please. This is also a summary of the APIs, the proposed required standards, and the recommended implementation guides that are part of the Interop 3. Alex just went over this. I just want to point out that the proposed required standards are based on the 21st Century Cures Act updates of the ONC certification criteria. As you can see, all of the APIs are based on Fire Release 4.0.1, US Core 3.1.1, the SMART framework, and the OpenID. In addition, the APIs for provider access and payer-to-payer exchange are also include the support for the Fire Bulk Data Access Standard. Based on the ONC Standard Version Advancement Process, or SVAP, and the language regarding updated versions in the proposed regulation, newer versions of these proposed standards, with the exception of the HL7 Fire 4.0.1 release, will have updated versions of the standards for implementers to consider. As we go through the remainder of this presentation, we'll review the recommended Da Vinci implementation guides associated with each of the NPRMs defined in the regulation. Next slide, please. This is a use case readiness slide that depicts the Da Vinci use cases and provides a graphical representation of their maturity and adoption. The use cases circled in red will be reviewed on the call today. Each will be presented in relationship to the proposed Interop 3 NPRM APIs or as an alternative to the proposed standards for attachments. Next slide, please. The first Interop NPRM API we'll review is the Patient Access API. The Da Vinci IGs that are recommended to support this API include the Payer Data Exchange, or PDEX implementation guide, and the PDEX Formulary IG, as well as the Karen Blue Button IG, which we will not review here. Next slide, please. CMS guidance recommended PDEX and PDEX Formulary to support the requirements in the Interoperability and Patient Access API final rule. As Alex mentioned, new requirements in the Interop 3 NPRM are focused on supporting the exchange of members' active or in-process prior authorization information, along with specific accumulators regarding services used to date. These requirements are supported by the current version of PDEX. Some of the benefits: it creates a full picture of patient activities known to the payer, providing coverage for the member or patient. Providers may be unaware of all the patient's clinical activities outside of their facility. In addition, payer-based data expands the scope of information available to the patient and provider to support clinical decision-making and care planning. And this improves the quality of information shared by using the FHIR standard. Next slide, please. The two Da Vinci implementation guides, along with the Karen Blue Button IG, satisfy the CMS requirement for covered payers to share a member's clinical and administrative data with the applications of the patient's choice. Each of the IGs exchange PHI and requires authentication and authorization for the consumer-based application to access the FHIR APIs presenting the member's information. Next slide, please. This slide defines the separation between the administrative data for claims and encounters that is contained in the payer's claim system that is exchanged by the Karen Blue Button IG standard and on the right-hand side of the drawing, and the clinical content defined by the United States Core Data for Interoperability, or USCDI, that is contained in both the payer's clinical systems as well as part of the claims and encounter record that is made available through the PDEX FHIR API. Next slide, please. The PDEX Formula IG defines a standard to query, retrieve formula information. It supports formula information based on the member's current plan via the Patient Access API. A shopping experience to compare multiple formularies with regard to covered medications and specifics of coverage, such as drug tiers, copay and co-insurance, PA requirements, are provided or supported by the PDEX Formula IG. The benefits for the patient include the ability to understand the drug formulary coverage and costs, compare the plans with other plans to determine the best available options. Next slide, please. The Provider Access API is the next Interop 3 NPRM API we'll review. The Da Vinci PDEX and Karen Blue Button IG are recommended to support this API. As a reminder, the proposed required standards also include the FHIR Bulk Data Access IG to simplify the exchange of data from multiple patients. Next slide, please. PDEX, or the Payer Data Exchange, defines a standard to search for and retrieve clinical data as defined by USCDI version 1, available from an ONC 21st Century Cures Act FHIR R4 API using primary profiles defined as part of US Core 3.1.1 specification. As indicated in the graphic, there are a number of sources of clinical information that may be persisted by the covered payer: CDAs, alerts, immunizations, lab testing, PBM medication dispense. In addition, claims information contains information that falls within the CMS USCDI definition of clinical data, for example, procedures. We should note that the regulation excludes the exchange of financial information as part of the Karen Blue Button portion of the API solution. Based on the new Interop 3 NPRM requirements, PDEX also supports the exchange of prior authorization information as we have previously described. To facilitate the exchange of payer information regarding the cohort of payer members in the provider's panel, Da Vinci supports the exchange of data for multiple patients via the Bulk Data Exchange standard using the Member Attribution List IG, which is referenced in the NPRM preamble, but not in the list of recommended IGs. Next slide, please. The Member Attribution IG provides trading partners the ability to establish, validate, and maintain a list of shared members. This aligns with the CMS data at point of care, giving providers access to Medicare claims data for their Medicare patients, and the Beneficiary Claims Data API, which serves ACOs participating in the Medicare Shared Savings Program and other eligible CMS alternative payment models. Next slide, please. The general workflow for the data consumer, for example, the provider, is to create a list of shared members, and then both the data producer and the payer and the data consumer maintain that list. The list is the input to the bulk data access process to extract requested information for all shared members in the list and to make it available in the IND.json format for easier exchange of large volumes of data. Next slide, please. In the third interop NPRM API, which we'll review, is the provider directory API. The Da Vinci PDEX Plan.ig is recommended to support this API. Next slide, please. This IGA defines the API that exposes a payer's provider network, including pharmacy locations where appropriate, for access by a consumer or provider application. This is a query-only API and does not support a put or a post, meaning you can't update information through this API. Recent additions to this include the ability to have catastrophic options in the insurance plan types and the ability to manage provider directory lists for incoming and outgoing providers, so we can support transitions across the end of plan year. Next slide, please. The fourth interop 3 NPRM API we'll review is the payer-to-payer API. The original requirement in the interoperability and patient access API rules was for required payers to support a payer-to-payer exchange of the patient's US CDI information at member request. No standard was identified. The current NPRM is focused on using the same standards as recommended for the provider access API, the Da Vinci PDEX and Karen Blue button, with the addition of the payer coverage decision exchange ID to support specification of current treatments. We should note that the regulation excludes the exchange, again, of financial information as part of the Karen Blue button portion of the API solution. Based on the new Interop 3 NPRM requirements, PDEX also supports the exchange of prior authorization information as previously noted. Again, to facilitate the exchange of information regarding the cohort of payer members in the providers panel, Da Vinci supports the exchange of data for multiple patients via the bulk data exchange standard using the member attribution list. Next slide, please. To make peer-to-peer exchange work as a business-to-business transaction, PDEX has defined a method for two payers to agree that they share a common member, to establish a secure connection, and to exchange the shared members' information as FHIR resources consistent with the required and recommended standards. Next slide, please. The Da Vinci Payer Coverage Decision Exchange Implementation Guide provides the ability to specifically exchange member information regarding active conditions and treatments. This information includes current treatments and services, conditions or diagnoses supporting each treatment, clinical guidelines referenced where appropriate, the scope of authorizations where appropriate, and supporting documentation. This allows a new payer to go and ensure, where possible, that treatments for the currently active treatments that the patient is receiving will be continued without interruption. Next slide, please. Finally, we'll review the Da Vinci support for the prior authorization requirements, documentation, and decision, or party API. The relevant Da Vinci IGs are coverage requirements discovery, documentation, templates, and rules, and the prior authorization support. Next slide, please. This graphic demonstrates how the three IGs work together to support the party requirements. First, coverage requirements discovery, and we'll go into it in detail, allows for the discovery of individual services that are being ordered that will require prior authorization. Documentation, templates, and rules allows for the automatic and collection of information from the patient's record, as well as query for the provider to provide additional information that's currently not available in the record to support the documentation requirements for prior authorization. And then finally, the prior authorization support implements the ability to exchange information, starting with a FHIR bundle, going through a translation into and out of the required X12 in 278 transactions to communicate the information to the responsible payer. Next slide, please. Coverage requirements discovery implementation guide supports the ability for providers at specified points in the clinical workflow to request information from the responsible payer regarding coverage and documentation requirements for planned treatments, referrals, and diagnostics. Next slide, please. This slide depicts the exchanges within and between the provider and payer to support CRD. CRD takes the guesswork out of patient-specific coverage by sharing authorizations or process requirements in clinical workflow where appropriate. It exposes information about patient benefits when the care team is most likely with or near the patient, so options can be discussed and decided upon. It may be triggered at scheduling time, during the ordering process, on demand, or at the end of an encounter. It responds with a need for prior authorization and points to documentation requirements with the ability to link to documentation templates and rules. It may return an authorization if there's sufficient information and the payer supports early determinations. There's some new capabilities that we've introduced in this next update of the CRD implementation guide. We've added specifications for additional clarity and to improve functionality. We have explicit expectations with respect to performance and accuracy of the CRD services, and it uses system actions to automatically execute responses rather than having the provider manually intervene. We also allow the inclusion of a questionnaire response and determination from the payer to the provider. Next slide, please. Documentation templates and rules builds on the CRD implementation guide to specify how payer-specific rules regarding required documentation can be executed in a provider context. Provider burden will be reduced because of the reduced manual data entry. Electronic questionnaires from payers utilizing CQL or clinical quality language can automate the extraction of data from the patient's record to pre-populate required information rather than have the provider manually enter it. Next slide, please. DTR uses context of CRD, provider, the patient, the orders, and retrieves templates and the associated pre-population rules from the payer. There's no need to re-enter the information. It retrieves information from the patient's medical record and pre-populates the template, eliminating duplicate entry. It queries for missing information specific to the service requested, and it can support complex guidelines that can be handled with what's called adaptive forms that solicit from the patient's record or provider relative information based on the prior or based on the answer to a prior question. So effectively traverses a complex guideline, only touching the nodes that are relevant. This dynamically reduces the need for large amounts of clinical information and a large requirement for complex questionnaires. The process replaces the need to request, gather, and submit documentation. New capabilities in this updated version include specifications that have been added for clarity and improve the functionality, required support for the SDC adaptive questionnaires, support for multiple launch modes, which include launch from CRD, standalone launch, launch from prior authorization support, and launch from the CDEX exchanges. We do support the use of the questionnaire response from CRD and support the ability to return a service determination in DTR when you're using the adaptive questionnaires, as well as what could be returned in DTR or CRD. We support the ability to hand the documentation bundle to prior authorization support for submission to the payer, and the ability to support handling the documentation bundle and a determination, if one exists, to the post-acute orders implementation guide to hand information from the ordering provider to the performing provider, including documentation and determinations that have already been made. Next slide, please. Finally, prior authorization support defines the FHIR-based exchange to enable the provider at the point of service to request an authorization, including submitting all necessary clinical information that has been collected through DTR to support the request, and receive immediate authorization from the payer. Next slide, please. PAS supports the ability to use a FHIR bundle to exchange PA information between the provider and the payer using an intermediary service to convert the FHIR bundle into and out of the HIPAA-specified X12N 278 transaction. New capabilities in this updated version of the guide include standard error responses and their processing, the ability to use DTR to ask for additional documentation where necessary, and several updates for inconsistencies that existed between PAS and the X12 278 transaction as supported in X12's GLASS. Next slide, please. Some of the key benefits from implementing CRD, DTR, and PAS include standard interactions across all payers, provide real-time access to payer requirements for prior authorization, support clinical workflow activities to trigger interactions with payers, to enable workflow to be performed by appropriate persons, and to avoid duplicate entry of information. Next slide, please. The adoption of CRD, DTR, and PAS will provide specific benefits for patients by giving patients and providers the ability to see and discuss alternatives for care that may include out-of-pocket cost considerations. They'll also support more rapid treatment approval to avoid unnecessary complications. Providers benefit by providing real-time access to payer requirements, automating the collection of supporting documentation, and standardizing multi-payer workflow. And finally, payers benefit by improving relationships with members and providers, tailoring workflow to the specific service and member situation, and having the ability to engage the provider at the time of decision making. So I'd like to thank you for the opportunity to present today, and I will turn this presentation over to Dan Kalwa to present the proposed administrative simplification rule for attachments. Dan?
Hello, and good evening. Thank you, Bob. I have the dubious pleasure of following Bob and being before Viet, so we'll see how this goes. My name is Dan Kalwa, and I'm one of the primary authors on this proposed rule, and I'd like to review some of the provisions with you this afternoon and perhaps explain some of the thinking that went into the proposals so that as you consider your comments on this proposed rule, you'll be able to take those ideas into account. Next slide, please. So there are a couple of things, and you may have heard this before, that act as limiters or bumpers on our decision making. The first is HIPAA originally altered the Social Security Act and identified healthcare claim attachments or a healthcare claim attachment as one of the transactions for which the Secretary had to adopt this standard. It also identified electronic signatures as a standard under administrative simplification that the Secretary had to adopt the standard for. Neither of these at this time have an adopted standard under HIPAA. It's also worth noting that the Affordable Care Act revisited this later and implemented a specific requirement with regard to the implementation of healthcare claim attachments in that they must be consistent with the X12 version 5010 transaction standards. And effectively, that statement, or the way HIPAA works, means they must be consistent with the implementation specifications of the X12 version 5010 implementation guides that have been adopted. Next slide. And so one of the things we considered was in considering this proposed rule is that first, if we were to propose standards only for health claims attachment, we would have effectively split the processes into two separate sets of standards, while at the same time still leaving the 278 as a requirement for prior authorization. So what we are proposing in this rule instead to do is adopt a standard for healthcare attachments as a more generic definition, and then allow for the use of those attachments in both healthcare claims to support healthcare claims processing as well as prior authorization. The next thing we're proposing to do is to adopt an implementation specification as well as a more general definition for electronic signatures, plus a more specific implementation specification to be used in conjunction with these healthcare attachments. And then finally, as part of this process, and I will describe it a little bit more later, we're proposing to update the 278 to 6020 in order to bring it in line with the other implementation specifications that we're proposing in this rule. Next slide. And so what we end up with is essentially a set of implementation specifications that meet the requirement for being consistent with X12 5010. And then we have a set of implementation specifications that have been proposed by NCVHS, even if they are older, and are adoptable, therefore, and then a set of electronic signature standards that, quite frankly, has been sitting since the original adoption of a HIPAA 25 years ago or more now. Next slide, please. And so the first thing we had to do was define exactly what attachment information means in the concept of attachments under HIPAA administrative simplification. And I know everybody believes they know exactly what it means, but we have to be more specific. So in this HIPAA administrative simplification definition, an attachment is information that a health plan needs to make a decision about healthcare that is not already included in the claims implementation specification or the prior authorization specification. And so we're explicitly attempting to eliminate the possibility that that data or those data elements could drift into attachment information and be required somewhere else, thus breaking the usefulness of the standard. Next slide, please. And so I've given this is a list of what we are proposing. So it would be the set of the 275 implementation specifications. And the primary driver for proposing to utilize 6020 was a technical fault in the original 5010 that could cause encoding problems if we were trying to use that guide. So we've gone to the next available. At the time of this publication, we still don't have a newer available guide that also fixes that issue. And then to match that, we're proposing the 277 implementation specification, which would be a request for additional information that generally would come from a health plan, sometimes before payment for a claim or after claim payment to request additional information. And then finally, as I already alluded to, as part of that set, we're proposing to update the 278 to come in line with the other transactions specifications that we're proposing to update. I want to note here, we are not proposing to require an update to the claims at this time, and none of these requirements change any health plan coverage rules or other requirements for supporting claims payment or prior authorization. This is just to enable that process. It makes no changes to that requirement, any requirements that might exist as part of the plan coverage policies. Next slide. I haven't seen, oh, there we go. The internet's a little slow today. So what we have proposed, and this is based on admittedly an older NCVHS recommendation, would be a set of the CDA guides to be included in the 275 as essentially the transport wrapper, and then transport it according to operating rules that may be proposed later. It's worthy of noting that generally in HIPAA, first, the standard that is adopted for each transaction is the implementation specification. So despite how the industry might use it elsewhere, the standard is the implementation guide or specification. It is not any underlying standards. And second, the implementation specifications are required to be adopted down to dated materials. So for example, you can see here, we're talking about very specific dates plus any errata. It is not possible to adopt open-ended adoptions of implementation specifications according to the rules of the Federal Register. Next slide. And so we are additionally proposing to adopt a definition that has not existed before under HIPAA for electronic signatures. So I encourage you to take a look at that and read it. If you're familiar with other definitions elsewhere in regulation, you'll note that it's very similar in structure with only a few terms switched out in order to make it more relevant to HIPAA and healthcare in general. And we are also specifically proposing to adopt the as a specific implementation of a type of electronic signature, the Digital Signatures and Delegations of Rights Guide. It's been pointed out to me since this release that there may be some regulation text missing that explicitly adopts this, but I can assure you, and please, while you're considering your comments, presume that this was correctly included. We're working with the Federal Register to clarify that. Next slide. And so one of the things that is worth considering with compliance states, for those of you that are familiar with the HIPAA process of adopting new standards, generally the compliance states work as no later than 24 months from the effective date for large health plans and no longer than 36 months from the effective date for small health plans. You'll note there that there isn't necessarily a requirement on providers to comply. It's health plans must be prepared to receive no later than those dates. However, the section of the Affordable Care Act that I mentioned earlier actually places a slightly different timeline on the Secretary for healthcare attachments, and so the effective date, the compliance date from the rules effective date would be restricted to 24 months for health plans. And so that is a short version. If you would go to the next slide, please. I would also like to note that in general, the Secretary has the ability when making a modification to an already adopted rule. So that means there's already a standard, and this is merely an update to that existing standard. Theoretically, the Secretary can assign a compliance date as short as no sooner than 180 days after the effective date. For this process, that doesn't seem reasonable to us, and there really is no reason to require earlier compliance than the rest of the process. So we're proposing the same 24-month effective date for the update to the 278. I do want to note that absent any action on the 278, it still will remain as the required standard under HIPAA for prior authorization transactions as defined in the regulations. So even if we do not adopt all of the provisions as included in this NPRM, we are also not removing any existing regulations at this time. And so next slide. So we have additional resources if you want more information about how the administrative simplification process works, how the HIPAA process works, and more importantly, if you want to look into an exception. I know HL7 Da Vinci has done a lot of great work with the exceptions processes and is already in progress with one, testing some of those implementation guides that Bob mentioned. And then finally, next slide, I'm not sure if anyone was on the previous listening session, but we do a deeper dive. We're planning to do a deeper dive into the provisions and some of the background and some of the specific provisions on a listening session on February 8th from 2 to 3:30. It will not take an hour and a half. We've just given ourselves a lot of time, but I do encourage you to sign up using the links in the previous slide and join in if you haven't already participated in our more in-depth discussion. And with that, I can pass it over to Viet.
Thank you. Thanks, Dan. So I get the pleasure of batting cleanup for this great panel. And the next part of this presentation aligns with what Dan just presented in the general sense that the work that I'm going to discuss here as part of the Da Vinci activities is around our implementation guide called Clinical Data Exchange. So next slide, please. So this implementation guide has actually been in the works and was begun many years ago. And very recently, we brought a STU2 version of the guide back to ballot because we wanted to add additional functionality. And we euphemistically call this guide a Swiss Army knife, in that it provides both a specific approach to exchanging clinical information as well as being a backup approach for supporting exchange of clinical information, not only between payers and providers, but as a clinician, and very importantly, between providers. And so the significant updates in this updated version is the ability to submit this clinical data to payers for both solicited and unsolicited requests from the payers to the providers. So next slide, please. The concept here is that using FHIR to both perform the request for information in a structured way, as well as allowing the receiving party, the clinician, to review, if necessary, that request and then complete the request using FHIR by having FHIR in the systems, gathering the structured clinical data, packaging it up, and returning it to the requester. So the requester may be a payer for specific clinical information, or the provider may be packaging up information in advance of the request, such as when doing a referral to another clinician. Frequently, when we send patients from our primary care offices to a specialist, we often send information, and we try to send as much information as we think they need, but oftentimes they may need additional information. So the hope here would be that for information we can send in advance, we send it, and when a specialist or another entity needs more specific information, they can make that request, and it can be fulfilled programmatically using the FHIR technologies. And then we think this is a great way also to augment additional workflows that we're addressing in Da Vinci, including the exchange of quality information and risk adjustment information, and then other paradigms as well, because in those processes, we have very specific information we're requesting for quality measures, inclusion, exclusion criteria, or for risk. We share specific information, but at times we need to augment that information to support the measures and such. And so this CDEX implementation guide supports that augmentation method for requesting and receiving additional information. And this work, of course, having been done over the last few years, was done prior to the attachments proposed rule that Dan just described, but it was in anticipation of the notion of, as we're transitioning to this new paradigm of information exchange and using FHIR and APIs, we wanted a method that the community could look to exchanging this clinical information. So we also included functions such as the digital signatures as well, and both the broad electronic digital signatures definition, as well as the digital signatures that we've developed in Da Vinci and in the FHIR community. So next slide, please. So this is just a high-level kind of workflow. The notion here is that a payer may request very specific information, say a post-payment review or submitting information to support a claim, and they could make a request to the provider. That request would be in a structured form that identifies specific clinical information down to specific lab observations, clinical documents, conditions, anything that could be supported by the US core and US CDI, they could put into this programmatic request. The provider could review that request and then have their system gather the information and send it back to the payer, or in a high trust relationship or in a contractual relationship, the request could be fulfilled automatically. Additionally, the provider can also submit unsolicited attachments as well. Next slide. So this is really a summary of what we want you to take away from this, is that the work in CDEX, based on surveys of our Da Vinci community, was widely supported. With a survey we did at the end of last year, with 79% of our members looking to expand their investment in using CDEX for these various scenarios that I've described, along with the ability to leverage the work that they've already done in Patient Access API and the EHR vendors have done to leverage FHIR to expand its FHIR capability in supporting the clinical data exchange. So we have great support from our Da Vinci community, and we hope that those of you who are not participating in Da Vinci will come join us on our calls and to participate in our Connect-a-thons and be able to further test these capabilities of CDEX. And what we anticipate doing as well is to build a library of these packaged requests. You can imagine the clinical societies being able to articulate the kind of information they want from their primary care providers when they're getting requests for specific specialty referrals. If we can start to create those templates, we can save a lot of time and actually lots of burden for clinicians who have to gather this information or request that information when they're sending data either to other providers or back to payers. So with that, my time is pretty brief, so I'd like to hand it back to Jocelyn for our Q&A period. Thank you.
That's great. Yeah, thank you so much. And I'm just going to say first, thank you to everyone, because that was an incredibly tight schedule, and where we got a little off, people made up for each other. So thanks for the collaboration. I invite folks to come back and join us. I do appreciate that our colleagues from CMS are a little limited in the commentary that they can provide during an open comment period. But I do think maybe there's a couple clarification questions that we can screen. And just a reminder to folks that are on the phone, if you haven't already, you can ask questions through the question panel. Hey, Bobby, you coming back to join us? Because I was going to pitch the first question to you. Thank you, everyone. That was really, as somebody that lives and breathes this every day, a very comprehensive overview of the content that we needed to get done today. So, hey, Bob, there's a question in there, and I'll ask you, and then Alex and Mary can weigh in if they're comfortable. Just about the ability to view the translation between the PAR D, I'm going to emphasize the D in that, PAR D rule, and the 3 IGs and what that crosswalk is. So can you maybe talk to folks a little bit about sort of that clarifying that, and maybe Alex, if you can chime in on sort of the rationale of like, why aren't we just using the name of the guides?
Well, all with the exception of PAS, the other 2 guides were written with the idea that they could be used for things beyond prior authorization. So I think what we're looking at doing is providing some very specific workflow diagrams that can be included in the guides to go and say, if you're doing prior authorization, here are the pieces of this guide that really matter. And that will help us when we start to think how those 3 guides could implement the requirements that the proposed rule has created. That make sense?
I think it does. Alex, can you provide any commentary about sort of the why aren't we just calling it by the individual use case names, and the thought process about that from a CMS perspective?
Sure. Well, first of all, we love making complicated acronyms. So the longer we can make a name, the better. As Jocelyn said, it's the prior authorization documentation decision. Yeah, it's a long name. Taking suggestions on shortening it. But so it is 3 separate implementation guides, but in this context, it is one prior authorization process. So while we could refer to it as the guide, and while many payers may implement this as 3 separate APIs, 3 separate things, we are combining it for the purposes of this prior authorization proposal and referring to it as a suite of APIs, if you will, and one sort of overall prior authorization end-to-end concept. So so that is the rationale behind it. If again, like I said, taking suggestions for the names, but we wanted to make sure that we were covering, all of the functions and all of the implementation guides within that title.
And Alex, while you were presenting, and I've heard you do this clarification a couple of times now in these types of readouts, there was one clarification around the omission of drugs. And I think that the question that always comes up for folks are drugs that are covered under the medical benefit. is there any additional clarification that you can offer there, or are we just expecting folks to sort of provide in their commentary their thoughts on that drug only, the drug exception?
Yeah. Before I give any response to that, what I'm going to say is I want you to comment on that. If you have questions on that, please include it in your comment letter. As we say in the rule, we are excluding drugs. So payers may choose to use the Part D API and other things for, like, for example, in the patient access API, you may want to alert a patient as to their prior authorization status for particular drugs. And we don't say, that's not prohibited by any means. So, encourage you to do that for transparency purposes and other reasons, whatever y'all would like. But we are excluding it from our requirements in policy.
Awesome, thanks. And then I would say more generically, because I know that the rule itself, I think, expounds on some of the background information. There's a couple of questions commentary-wise that have come up about the exclusion of fire from the attachments rule. So I don't know, Dan, if there's anything that you can sort of expound on there in reference of what's actually, highlighting some of the content that's in the proposed rule language itself.
So I can talk about, I think, what I talked about last week at NCVHS,
right,
and the requirements for consideration. And so one of the things I think it's vitally important for the industry to understand is that in order for it, there needs to be an implementation specification for each transaction, and it does need to go to NCVHS before it can be considered. And so to the extent that, just like we discussed publicly last week at the last standard subcommittee meeting, that would need to go to the DSMOs, the designated standards maintenance organizations, and that would need to be forwarded to NCVHS. And then it would go through the exact same public comment process that we did last week with X12 and CAQH Core for the operating rules. And then at that point, when the secretary gets a letter, then it's on the menu for HIPAA. And so to the extent that the industry is willing and able to go through that process, and I will also, I will pump the same topic that I always talk about, to the extent that you have testing. I know this group in particular is well aware of that, but to the extent you have testing, return on investment, opportunity costs, training costs, whatever you can collect, that goes a long way towards speeding the implementation of standards.
I'm reviewing the questions and figuring out which ones I can actually field for you guys. I guess maybe in complement, Dan, to the comments that you just made, can you maybe provide a little bit of color about the HL7 commentary around the attachments topics that were covered last week? Maybe I'm putting you on the spot here, so I be as brief as you want to be. But the commentary that came from you, but also from some of our early implementers, the commentary that came out of both Kirk Anderson from Regions and Anna Taylor from Multicare. Hey, we can't hear you.
Sorry about that. So following on Dan's comment, we actually do intend to work through the process through the DSMO. For those who are not policy wonks, including me, was the designated standards maintenance organizations, which is a X12, NCPDP, others, including HL7, to have them convene and kind of review the proposal and offer a recommendation to NCVHS. We did participate in NCVHS's two-day subcommittee hearing on standards, and on the second day we were asked to comment around operating rules. I would refer folks to our official response to the request for comment from NCVHS regarding the rules. But what we wanted to add on top of that response really was kind of taking a moment in history, I would say, that we're in a transition. And I noted in that presentation was that the fire timeline in HL7, really started in 2011, which is significantly after the paradigm and the regulatory activities that surround how HIPAA transactions are mandated and operating rules and such. And over the last 12 years with fire, we have matured a process in HL7 that not only includes the standards development, but also the engagement of the community around testing, and the details of our guides and our API guides really provide the details, information around syntax and semantics and connectivity to support the implementer community. And so we came and really just said that we believe that that content is sufficient, that additional operating rules are not necessary, and where there are details or gaps needed, we have the mechanisms within HL7 and our feedback process and our balloted process to support the community in those updates. So I think that might have been what you were asking me to refer to, and so we also discussed briefly about CDEX, but
yeah, I think maybe the only other piece that I would echo there that I heard in the testimony last week was the idea that this idea of being able to move to the minimal necessary information to be shared, as you heard Bob really draw out in the interactions, right, that we're looking at for the guides, especially around prior authorization, this ability to get to that codified data set and exchange only the data needed, I think really resonated in the testimony from two of our early adopters out there in the Northwest. So.
yes.
I'm going to take a pause and actually allow anyone that presented today to, if there's any sort of final thoughts or commentary that you want to provide to this audience. You have had really great attendance and attention throughout today's session. So if there's any parting thoughts, and I'll start with Dr. Green at the top and see if anybody else has anything else they'd like to share with the group before we wrap.
I just want to, again, thank everybody for their interest in improving prior authorization, and whatever role you play on that, whether it's just taking information back to your organizations and letting them know what the opportunities are here, or actually digging into the technology. Everything that everybody is doing is helping. And hopefully one thing, additional thing that you'll do is provide comments to both these roles so we can move forward too.
Awesome. Anyone else have any other parting thoughts? There is one question that popped in with some questions around how to participate in the FHIR-only version. So Bob, I'll actually hand back to you to talk a little bit about what it means to actually be allowed to be in the exception process.
Okay, well, let me first of all say thank you to our colleagues at CMS. There's no better way to make sure that we move the ball forward in managing healthcare information and providing good healthcare services than to create regulations that go and enforce standards that have been created by the standards organizations. So, thank you very much. As far as participating, sorry, repeat your question. I apologize.
Exception. Can you just give a little bit of just a 2-minute on the exception, and then I'll close us out and just tell people where to get more information. So. Okay.
We went through, Da Vinci went through the exception process to go and be able to bypass the use of the 278 when you're using PAS, so to avoid the ability or the need to translate into the X12 and 278 and out of it. That request was approved. There's a very formal process that's specified under the Accountable Care Act, and we went through that, and we're in the process of testing the specification, collecting information, and then ultimately that has to be presented back to CMS, and I believe it's ultimately published in the Federal Register as kind of the first step in the process before we take it back to NCVHS, and then, assuming NCVHS agrees, provides a recommendation to the Secretary of HHS. Did I get that correct, Dan?
I think you got a thumbs up.
That's correct. Yep.
Okay.
Yeah, and I would say Bob and Dan were masterful, I think, in the work together to really lay out a process that was accessible and that people could participate in, to really make sure that we can get that FHIR to FHIR exchange. And I would do a little bit of a clip note just to share with folks who haven't been coming monthly. There's some great presentations from this fall where our colleagues from Multicare and from Regions, and I know they've added additional payers and providers since then, share some of their early experiences in doing that pure FHIR implementation of the Da Vinci guides for prior authorization. They're seeing really good progress. So I want to thank everybody. You guys really are amazing. This work is important. It is human powered. To Mary's point, we have made the progress we have because people are showing up, participating, using this work. If you need to know more about Da Vinci and you didn't see a URL today, you can always drop an email to the Da Vinci PMO at POCP.com or join our listserv. And I would do a plug for anybody that is interested in the exception. We've had a couple questions come in. You do need to be a Da Vinci member or working with a payer that is a Da Vinci member. So there is on the Confluence pages that Leslie has been dropping links to more information about joining as an official member of Da Vinci for versus just participating in the community. And we're always excited to make the vote a little bit bigger so that folks can get involved, not just in implementing, but also in the governance and the direction of where we're headed from a program perspective. So everybody have a great night. Thank you for everybody for keeping us on time tonight, and really excited to see the comments that are going to be coming from folks. And Da Vinci will be working really hard to publish our comments on both rules by early March, so that they can hopefully be references for you. And we'll try and get as much guidance out ahead of March to let you know sort of the spirit or the sort of direction of where our commentary is headed more publicly, depending on how much agreement we can get across to members about how bold we are in our statements. So thank you, everybody. Have a great night. And we will be here again next month. In the meantime, follow the listservs and reach out if you have any questions at all. Thank you. Thanks, guys.
Thank you very much.
Thank you.